Good morning or afternoon, depending on where you're located, and welcome to today's informative webinar, Building a Culturally Inclusive Workforce, Building Trust, Enhancing Care, Cultural Humility in Healthcare. We are delighted to have you join us as we emphasize skills and knowledge that value diversity and enable effective responses to cultural differences while raising awareness of personal bias. Today, we are here to help facilitate this discussion between traditional and modern healthcare practices to make healthcare more culturally inclusive and patient-centered. My name is Molly Siegel. I'm a public health associate with the Technical Assistance and Research Center, better known as TARC at NCUIH. Joining me from the NCUIH team are Elizabeth Beth, Program Manager of Technical Assistance, Evelina Maho, Director of Technical Assistance, and Amy Lord, Web Administrator of Communications. We are honored to have you all here today. We kindly ask that you place your name, organization, tribal and tribal affiliation into the chat box. Next slide, please. I have a quick disclaimer. This event is made possible by Indian Health Services Cooperative Agreements Fund. The event is solely the responsible of NCUIH and does not necessarily represent the views of Indian Health Services or the Department of Health and Human Services. Next slide, please. For those of you that are unfamiliar with the NCUIH, here's a little background. The National Council of Urban Indian Health, also known as NCUIH, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is a national representative advocating for the 41 urban Indian organizations, better known as UIOs, contracting with Indian Health Services under the Indian Healthcare Improvement Act. NCUIH strives to improve the health of the over 70% of American Indian and Alaska Native population that live in urban areas, supported by quality, accessible healthcare centers. Next slide, please. Another quick disclosure, since this is for credits, we've got a few more. There are no relevant financial relationships with ineligible companies for those involved with the ability to control the content of this activity. Bear with me, just a couple more stuff on CMEs. Next slide, please. This activity is jointly produced by the National Council of Urban Indian Health, National Council of Urban Indian Health, and CARDIA Services. CARDIA Services is also approved as a provider of nursing continuing professional development by Montana Nurses Association and accredited approver with distinction by the American Nurses Credentialing Center Commission on Accreditation. The program is approved by the National Association of Social Workers as well. Both are for one continuing education CEU contact hours. So we're going to be talking more about that at the end of today's slide and into the next slide, please. Okay, so upon successful completion of this activity, one contact hour will be awarded. Successful completion of this continuing education activity includes attending the entire CE activity, completing the online evaluation, submitting in the online CE request. Your certification will be sent via email. If you have any questions about the CE activity, please contact Fiona Morrison Fleming. Her email is being dropped into the chat box. Next slide, please. Before we proceed, please note that this session will be recorded for education and quality improvement purposes. The recording will also be shared to make it accessible to those who may have missed it or would like to revisit the content at a later date. Next slide, please. Please note your mics have been muted upon entry. We always encourage participation and engagement in today's sessions. We invite all of the participants to turn on the camera and post questions and comments in the chat box. There will be an opportunity for a question and answer at the end of today's session. Next slide, please. As we continue our webinar, we encourage active participation and value your questions and insights. To make the most of this interactive experience, here's a link. Here's how you can ask a question on Zoom. Just click on the chat icon, type your question, and hit enter, and send it into the group. We encourage comments and questions in the chat box, and we'll have time at the end of today's presentation for a quick Q&A. Thank you. Next slide, please. All right, before we jump into today's learner objectives, and learning, let me introduce myself a little bit more before passing the introductions to my colleague. My name is Molly Siegel. I have been a public health associate with NCUIH for just over 2 years now. Prior to employment with NCUIH, I worked for the Florida Department of Health as a COVID-19 epidemiologist with special focus on K-12 population health. It's my privilege to be providing this webinar for you today, and I'm going to pass it over to my colleague Liz to introduce herself before we get going into today's event. Thanks.
Thanks, Molly, and so glad to be here today. As Molly shared, my name is Liz Best, and I'm the Manager of Technical Assistance here at NCUIH. Prior to my work at NCUIH, I worked in health communications for the CDC Foundation, and I was the Director of Contact Tracing and Patient Monitoring for the New Hampshire COVID-19 emergency response. Again, it's my pleasure to be with you here today, sharing this important learning topic with you. And back to Molly.
Thanks. All right, next slide. We're going to go over our learning objectives for this webinar. The objectives are designed to ensure that you come away with valuable knowledge to inform your community members. By the end of the session, you have a solid understanding of recognizing healthcare disparities. Participants will develop awareness of unique healthcare disparities faced by American Indian and Alaska Native communities, including historical, geographical, and socioeconomic factors. You'll be able to define and identify components of cultural humility. Participants will learn the definition of cultural humility and differentiate it from cultural competence, showcasing an understanding of its core principles. Speakers will describe key components of cultural humility, including self-awareness, respectful communication, lifelong learning, and tailored care. Apply cultural humility principles. Last one. Participants will actively engage in real-world case studies and interactive discussions with peers to apply cultural humility principles in practical healthcare scenarios, fostering a deeper understanding of cultural sensitivity. Okay, next slide. So what is culture? Culture is a dynamic, flexible, complex, and often individually defined. In the iceberg concept of culture, we can see culture broken down into 3 different parts. Cambridge Dictionary defines culture as the way of life, especially general customs and beliefs of a particular group of people at a particular time. This general definition is easier to break down in the iceberg model show, which we're going to go into a little bit more. So on the top, you can see the surface level. This is what can easily be seen. So think about a food, attire, celebrations. Right below it, you have a deep culture right underneath, and it takes higher emotional level and goes into things like concepts of food, attitude towards elders, and nonverbal communication. And lastly, at the very bottom is unconscious bias. This is the most emotionally intense and goes into a concept of self and notions of adolescence. So this one's a little bit harder to get into on the iceberg model. Typically, we stop at surface and go into maybe the middle part, but that last unconscious bias. But we're going to be touching more on bias towards the middle of our webinar today. So let's go to the next slide, please. All right, cultural influence on health. Culture impacts our everyday, including our health, from historical trauma we carry to dietary habits and traditional healing practice we take part in. These cultural influences on healthcare shape how we view our health and the health of others. So we have a couple on this slide: lifestyle, access to healthcare, dietary habits, even historical trauma, which we'll get into. So next slide, please. Awesome. The 2023 disparities in health and healthcare figure on the left of the slide shows how factors within and beyond healthcare systems drive disparities in health and healthcare. The social determinants of health, such as economic stability and safety, directly correlate to an individual's health and well-being. In healthcare systems, there's an overlap between a person's health disparities and the system providing care. In the model to the right of the slide, we can see the quality care gap widen between the minorities and non-minorities. The causation is in part due to disparities and dissimilarities in healthcare systems, influenced by the social determinants of health. These dissimilarities, such as access to care, patient preference, and clinical appropriateness, compound on top of existing health disparities, such as stereotyping and biases. There's going to be some articles dropped into the chat, as well as a bonus article not shown on this slide, that goes over disparities, psychosocial influences by Dr. Donald Warren of Johns Hopkins. I encourage you guys to click on them and read them at a later time. We just don't have time to really go into them fully, but they're good reads. Next slide, please. Intergenerational bias for American Indian and health disparities. So historical trauma is carried deep within American Indians and elective natives. This trauma starts before birth and is carried through a person's lifespan. There are different points intervention to reduce the chances of chronic diseases later in life, such as WIC or PDPIR. One of the largest, most impactful interventions comes when preventing childhood stressors. By providing culturally competent care and interventions, we can lower chronic disease disparities later in life. I like to point out on this slide too, the adverse adult experiences. We can see how parenting directly impacts the adverse childhood experiences. It's almost a loop. Some parts of it are a loop, way to think about it. But next slide, please. All right. Urban American Indian and Alaska Natives are not omitted from healthcare disparities and suffer higher rates of suicide, binge drinking, frequent mental disorders, and cigarette smoking. Deaths due to chronic liver disease, cirrhosis are more than double their white counterparts. So we pulled this actually from the NCUIH website. We can see just some of the terrible statistics on the screen compared to the general population. Or the white counterparts. Next slide, please. So let's go into bias a little bit more influencing health outcomes. It's important to recognize healthcare disparities and bias as a healthcare professional. Explicit bias is the traditional conceptualization of bias. With explicit bias, individuals are aware of their prejudices and attitudes towards certain groups, versus implicit bias involves all of the subconscious feelings, perceptions, attitudes, and stereotypes that have developed as a result of prior influences and imprints. So explicit bias, traditional concepts of bias, your stereotypes, your prejudices. Implicit bias, subconscious feelings and perceptions, stereotypes you've developed because of prior events or imprints. So a little bit back and forth there to remember. By recognizing both biases, you enhance your awareness and improve patient-provider interactions. It can be hard to recognize implicit bias as it's subtle. On the next slide, we're going to be giving some impacts of implicit bias that implicit bias has had. So once more, implicit bias, subconscious feelings, perceptions, influences because of prior experiences, versus explicit bias. That's your prejudices. That's your attitudes due to certain groups. But we'll go into implicit bias a little bit more on the next slide, please. So implicit bias may influence subtle behaviors and decisions impacting communication and patient outcomes. The 4 studies listed are unfortunate outcomes of implicit bias left unchecked. So I won't go into these, but a couple are being posted into the chat as well. For y'all to read at another time. I highly recommend that you go into these studies and just see the impacts of implicit bias by providers with the unfortunate outcomes, such as the American Indian, Alaska Natives, and Black women are 2 and 3 times more likely, respectively, to die from pregnancy-related causes than white women nationally. And this is due in part because of implicit bias, unfortunately. But like I said, we don't have the time to go into all of these wonderful studies that have been done to, make sure that these voices are heard, but I highly encourage it. And with that, I'm going to pass it over to my colleague, Liz, to go into cultural competency a little bit. Thank you.
Great, next slide, please. And thank you, Molly, for providing that context. I know for me, when I received my training, we used the term cultural competency. And so years ago, when I did training on cultural humility, I was very excited to see how this term evolved and how we can use it in practice. So before we dive deeper into the definition of cultural humility, I wonder how many of you are really familiar with this concept. So feel free to drop in the chat what cultural humility means to you. We'd love to hear your thoughts and perspectives. So just giving a little definition, cultural humility is a critical concept in today's diverse world, particularly in healthcare and social services. Cultural humility refers to a lifelong commitment to self-evaluation and critique, to understanding and respecting others' cultural backgrounds, and continuously learning from individuals and communities different from our own. Cultural humility is a journey. It's not a destination, and it requires ongoing commitment and effort. What I love about this definition as well, and I will share a quote, is to be teachable means to be open to making mistakes, even to welcome them as part of your learning process. So think about this in your work. We need to strive to be constantly learning, and learning not just from our colleagues and leaders, but from our patients as well. Next slide, please. So embracing cultural humility is not just a shift in terminology, it's a fundamental change in how we approach cultural understanding. As Shnigda Nanpati points out, focusing solely on cultural competency can lead to undesired consequences. The term implies that one has learned everything you need to know about a certain culture or group of people, which we know is impossible to do. When in fact, learning is a never-ending process. Cultural humility, on the other hand, emphasizes ongoing learning and reflection, which we'll practice today. It's about admitting that we don't have all the answers and being open to listening and learning from others. It is also about actively engaging with others, acknowledging that learning about different cultures is ongoing. It's about being open to new insights, asking questions, and seeking ways to understand others' perspectives. This shift in approach encourages us to see cultural understanding as proactive and ongoing, rather than as a static goal. And when considering your patient population or your community that you work in, it's important to recognize that no matter how much you learn, you can never know everything there is to know about someone else or their culture. Each individual is unique, as is each encounter with that individual. Next slide, please. So if we break it down further, cultural humility rejects the notion of being an expert on another's culture. It involves subjective practices like self-reflection, active listening, recognizing the dynamic nature of culture that Molly pointed out in the first slide, and identity. On the other hand, cultural competency, it's still important, but it implies achieving a level of expertise or mastery in understanding another's culture, viewing cultural understanding as the end product or state of being. It may imply the adoption of objective practices, such as learning specific cultural norms or behaviors, while potentially overlooking the ongoing nature of cultural learning and the uniqueness of the individual experience. Understanding these differences is crucial for fostering respect and empathetic cross-cultural interactions. Next slide, please. So we've already learned that cultural humility is a critical mindset in healthcare, emphasizing continuous learning and self-reflection. And by shifting from an expert to a lifelong learner, cultural humility places a greater emphasis on patient-centered care. For example, a doctor practicing cultural humility actively listens to a patient's cultural beliefs about health, integrating these beliefs into their treatment plan. This approach also acknowledges power dynamics, ensuring interactions are respectful and empathetic, and recognizing the limitations of cultural competence. Cultural humility allows healthcare professionals to embrace the complexity and diversity of cultural identities. This mindset fosters understanding and promotes patient-centered care by encouraging continuous self-reflection to address the biases that we talked about earlier. Overall, cultural humility leads to a more inclusive and compassionate approach to healthcare, and we will later discuss improves outcomes and patient satisfaction. And this screenshot is just the original paper by the authors who coined the term cultural humility. And I think it's going to be dropped into the chat as well. So next slide, please. So this clip is from a study on patient charting and applying cultural humility in patient charting. So just to share a little bit, applying cultural humility in healthcare, especially in charting, can significantly impact patient outcomes across various areas, such as readmissions, pain management, surgical outcomes, and general health. By incorporating a patient's cultural beliefs and practices into their treatment plan, healthcare providers can enhance patient satisfaction and health results, as this study shows. This was evident in the 2015 study, Unconscious Biases, Microaggressions in American Indian Healthcare, which revealed that experience of microaggressions were linked to worse mental and physical health among American Indians with chronic diseases. These experiences were associated with self-reported history of heart attack, heightened depressive symptoms, and increased hospitalization rates. These findings underscore the importance of cultural humility in healthcare, as it not only improves patient-provider relations, but also enhances healthcare outcomes and overall healthcare quality. And we'll drop this study in the chat as well for you to review. Next slide, please. So cultural humility, as you can see on this slide, offers benefits that can significantly impact the patient-provider or patient-staff relationship. By adopting a cultural humility lens, providers can build trust and rapport with patients. Trust is crucial because it fosters a sense of security and openness in the healthcare setting, leading to better communication, improved leading to better communication. Improved communication, in turn, reduces misunderstanding and ensures that patients' needs are understood and addressed effectively. Cultural humility also plays a role in reducing health inequities by acknowledging and addressing unique cultural factors that may contribute to disparities in healthcare access and outcomes. Additionally, it can enhance patient satisfaction by demonstrating respect for a patient's unique cultural beliefs and practices. Ultimately, cultural humility can lead to better treatment adherence, as patients are more likely to adhere to treatment plans when they feel understood and valued by their healthcare provider. So next slide, please. So how do we put this all in practice? We've given you some background and definitions. So moving on to the next slide, please. So for those of you who are social workers, cultural humility aligns closely with the principles guiding social work practice, enhancing the effectiveness and sensitivity of interactions with clients. The commitment to an ongoing process of compassionate self-awareness and inquiry, as emphasized in cultural humility, is essential for social workers. The commitment is further strengthened by engaging with a community of trusted and cognitively diverse colleagues, as it allows for a more comprehensive understanding of diverse cultural perspectives. Being open in your work and teachable, another core principle of cultural humility, enables social workers to continuously learn and adapt their approach to better serve their clients. Additionally, cultural humility encourages social workers to bear in mind that social structures that shape their clients' realities, helping them to provide more empathetic and contextually relevant support. And by integrating these principles here, social workers can practice with greater cultural competence and sensitivity, ultimately improving outcomes for their clients. So next slide, please. So take a minute to read the questions on this slide and raise your hand or drop an emoji in the chat if you've ever thought about these questions and how they influence your interactions with your patients or your clients. By reflecting on these questions, we can better understand ourselves, recognize our own biases, and approach our work with cultural humility, ultimately improving our relationships with those that we work with. So asking questions like, what parts of my identity am I aware with? What are the most salient? What parts of my identity are privileged or marginalized? How does my sense of identity shift based on context and settings? And what are the parts onto which people project and received by whom? And what might be my own blind spots and biases?
Liz, we have a question in the chat box by Vincent. The question is, can you speak about navigating differences in practice in Western medicine and best practices in tribal medicine?
Well, I think we're going to go into that with some examples, but I think it is listening, right? It's taking this approach to active listening and being guided by your patient, right? So often we think of ourselves as the expert, right? And holding all of the information. But patients are, they're very knowledgeable too as to, what they can comply to in terms of adherence. And so I think being able to bridge that gap is important in interactions. Great, next slide, please. Thank you for that question. So here's just an example I put together of putting communication in practice. And when we think about communication, right, think about your nonverbal communication that you're bringing to the table. It's as equally important as, your verbal communication as well. So take a moment to read the approach here and think about a time where you may have had to discuss a sensitive topic with a patient. This has to do with diet, which can be a tough topic to broach sometimes with a patient or a client. This slide, of course, is a hypothetical interaction between a patient and provider discussing diet and weight. When discussing weight or diet with a patient, a physician can demonstrate cultural humility by taking two different approaches. In the first approach, the physician might approach the conversation with a mindset of curiosity and openness, seeking to understand the patient's cultural background and how it may influence their views on weight and diet. The physician might ask questions as their perceptions of body image and health. And by listening actively and empathetically and not just providing guidelines, the physician can gain a better understanding of the patient's perspective and tailor their recommendations accordingly. In the second approach here, the physician might focus on self-awareness, reflecting on their own biases and assumptions about weight and diet. They might consider how their own cultural background has shaped their views and attitudes towards these topics and how this might impact their interaction with patients. By being aware of your own biases, this physician can approach the conversation with humility and sensitivity, avoiding judgment and working collaboratively with the patient to develop a plan that is culturally appropriate and respectful of the patient's values and beliefs. And this is sometimes tricky to do too, because we only have so much time with a patient, but really trying to take the time to look at your own biases and ask questions and ask your patient or client for feedback, in their own health planning. Next slide, please. So I love anagrams, and there has been a great one developed when taking an approach to cultural humility with patient interactions. This one is called the humble approach. It's easy to remember and is a great framework for healthcare providers to enhance and improve patient care. Each letter in humble represents a key aspect of this approach. And so we're going to go over them, and then we're going to do a little interactive activity together. So H, be humble about the assumptions that you make about knowing the world from your patient's shoes. Again, I believe we can never really be in anybody's shoes. And so that's where active listening really comes into play. U is to understand how your own background and culture can impact your care of your patients. M, motivate yourself to learn more about your patient's background, culture, health beliefs, and practices, as well as the unique points of view of their families and communities. And this is where there is space for this term cultural competency, right? Like knowing more about the patient population that you serve. B, begin to incorporate this knowledge into your care. L, always remember that it's a lifelong learning process, especially if you're working with younger generations. They have a much different approach to health than, somebody maybe one or two generations above. And then E, always emphasize respect and negotiate the treatment plan. Great, next slide, please. We're going to go read a case study, and then we're going to pull up something called a Padlet, and you will all have a chance to enter your own thoughts and comments into this Padlet. And so while I read this, Abby can drop the link to the Padlet in the chat, and you can pull it up in a different browser. So this case study, again, a hypothetical situation. Samuel, he's a 26-year-old American Indian who lives in Salt Lake City. He has decided to visit the clinic today for a well visit and to discuss the COVID-19 booster vaccine. He stands about 6 feet tall. He weighs about 300 pounds. He's wearing casual streetwear. He's got a hoodie drawn tightly around his head. His shoes are old and untied. His sleeves are rolled up, and he has a number of tattoos visible on his forearms and his neck. He sits with his arms crossed and his head down. He's unsure about the vaccine safety and effectiveness, and he has heard varying opinions within his community about the booster vaccine. But he lives with his grandfather who has COPD and diabetes and wants to make informed decisions about whether or not to receive the vaccine in today's visit. And the next slide will pull up the Padlet. And as you can see here, I have the case study. And then for each letter in the anagram for humble, we have a few questions. So I'd love to take, let's see where we're at time, probably 5 or 6 minutes, and to go through as a working exercise and just type in your responses, right? So for each, ask yourself what preconceived notions you might have about Samuel's background based on his appearance, right? How is he coming off non-verbally to you? And then reflect how you can assure that your approach to Samuel's health-related questions with humility. And then you can just go through each letter. And if you're unable to pull the Padlet up, you can feel free to drop in the chat as well. Any thoughts that you might have on applying this humble approach? And if it works correctly, we should be able to see your comments come up in this slide here.
So it's looking really good so far. I'm starting to see a few coming in. Definitely under the H and humble preconceptions, withdrawing, reflecting, being curious, ask instead of tell first, you know. He's telling you a little bit more about himself. Let him continue, you know, don't just automatically jump in and give your Western ideology or what it says in the textbook. For the U, I'm also seeing some stuff in terms of it. Culturally, his community, how are they feeling about vaccines? What baggage are they bringing about COVID experiences, especially his age? That's what I think too. I mean, a lot of these young adults now, their formative years, unfortunately got taken by COVID. So what additional baggage are they bringing to the table that maybe, you know, you as a provider didn't? I think that's really a great one to put in there. Yeah, non-compliance. I think it's awful when people see non-compliance. They're automatically kind of not looked at otherwise on their chart. So I think having that on someone's chart is just I wish they could just get rid of non-compliance on people's charts because there's so much misunderstanding in it. Yeah, uncomfortable, not judging assumptions. Yeah, more on COVID, how it impacted him and his family. Yeah, he didn't tell you if he lost anyone due to COVID, you know? He didn't go into why he was hesitant on the vaccine. So I think, we're oftentimes running out of time. It's taking that additional time to allow them to speak, and not judging them. Yeah. And then asking the question, yeah, what does he want to know about it? Instead of just feeding them facts that might go over their head, explaining, allowing him to have his concern, and especially around, his relatives. I think these are all really great. What do you think, Liz?
Yes, I think these are all really great answers. And before we move on, right, you can see how, and as Molly said, sometimes, we're really quick in a room. You just want to get the vaccine or give the treatment plan because you have a lot of work or other patients to go to. But taking a moment and really following, the H, the U, the M, the B, the L, and the E can really help with the patient interaction. And all of your comments are completely right on. So great, we'll move out of our Padlet and into our next slide. And forward it one more. So continuing how we can put this into practice. So in addition to applying the humble approach, healthcare providers must also have knowledge and awareness about various aspects related to cultural competence. So as I said, they're not mutually exclusive. These two concepts can go hand in hand. This includes understanding health-related beliefs, obviously from a more general sense, certain practices and cultural values of diverse populations that we work with. It's always important for providers to be aware of the incidence and prevalence of illnesses and diagnostic patterns among different cultural and ethnic groups, as this can impact diagnosis and treatment decisions. Additionally, having knowledge of treatment efficacy data for diverse populations is crucial for providing effective and culturally sensitive care. This might include learning about traditional healing practices, different views on wellness and illness, and the importance of spirituality in health. Additionally, the provider would familiarize themselves with not just the incidence and prevalence of diseases that disproportionately affect certain populations, such as diabetes, perhaps substance abuse, but by incorporating this knowledge into their practice and emphasizing respect using an approach like humble, the provider can tailor the care to be more effective and hopefully have better outcomes. So next slide, please. So what are some of the best practices for infusing cultural humility into every patient interaction, from when a patient walks into the door, to when you perhaps follow up with a phone call, checking in on the patient later on. We've already talked about self-reflection, active listening, and asking open-ended questions, but also hosting trainings on cultural humility or cultural sensitivity is important for staff on all levels and something important to continuously do, perhaps having it as part of your onboarding as well. Other things that are important to consider: having an interpreter, perhaps a cultural liaison or patient navigator can help to increase communication and build trust, and really give patients a little bit, or clients a little bit more time that might be needed to discuss their healthcare concerns. Lastly, having a continuous improvement loop for feedback and quality is always important. So having your patients fill out surveys to know how you as staff or clinicians can continue to make the patient experience a better one and to get it right. Next slide, please. So we're just sharing a few resources here. Additionally, we will share this this slide deck as well as the recording if you want to share it with anybody ELFs in your place of work. And we also have a document which will have these resources shared. But there are a lot of great trainings and learnings to go deeper. We only had, half an hour here today to go deeper into cultural humility as a practice. And they're listed here. And next slide, please. So that's it for our presentation today. We do have a few slides to wrap it up at the end, but we've got probably about 7, 8, 9, 10 minutes for some Q&A. So feel free. I know we have a large group here today, but feel free to drop it in the chat or come off of mute. Let me pull up the chat.
Yeah, I'm seeing a couple already in the chat, and I can dive in and you can dive in too, Liz, but there's one from Evie. How do you recognize your own explicit and implicit bias? So face value for me, explicit bias is extremely easy to recognize. So it's not as hard for my day-to-day to just, be able to turn that off. As it is implicit bias. So that's the one that, it's not necessarily the general stereotyping, but, your own experiences and what you bring to it, and how they influence you. So before I go into any kind of, patient care, or even creating this, I like to think, okay, I don't know anything about implicit, explicit bias. I am reading the definitions for the first time. That way I'm checking myself as if, I'm completely brand new to the subject area. There's nothing, behind me, which can be hard to do. I don't think anyone can ever be 100%, eliminating those explicit and implicit biases. But it's definitely making sure you're in the right headspace to have that viewpoint, to have that freshness, before you start looking at things, before you start talking to the patients that you're serving and the community that you're serving. So it might be taking a few extra breaths or, whatever it is to get your mindset in the right place. That's at least what I do. I don't know about you, Liz, in terms of recognizing your own biases.
Yeah, I mean, I think it's just, a lot of self-reflection. I think also we always tend to be, for me, like in a hurry, right? But really taking the time to listen. But here's another question. How do you bring self-awareness in another who may need to reflect on their own behaviors, actions, or biases? I mean, I think if you are, I'm seeing this as a question, if you're, working on training with members of your staff, right? And again, as we spoke to, I think a lot of it is a mindset and recognizing, right? Because we all live in our, in our own mind, in our own space. And sometimes it is difficult to see, how our own biases or our thoughts might impact others. And so I think having trainings which are more reflective in nature, not as much knowledge-based, and I think that's why we tried to break this training up, into both and putting it into practice. But again, it is a practice, and I think something that it does take time and work and a shift in mindset, especially for those that have been trained, in one way or another.
I think I put a comment in the chat, in the chat box too. This is Evie, but to April's question, I think also as an organization, really trying to create a culture, right? And this is really that practice of we speak, we do, we act, and we provide quality healthcare or education or whatever we do in public health or in a clinical setting, that everything that we do really points to what we stand by as far as our value system and our goals that we try to uphold. And so whether that's an annual training, maybe it's every 6 months, depending on, how you want to approach it. But creating that system level type of culture is also just really important. It supports you as a supervisor to reinforce, right? To have these conversations at annual evaluation or annual training, mid-year training, and just making sure that we understand what kind of standard we're trying to uphold as a healthcare center. So I think that's another way, in addition to that individualized type of approach. So I just wanted to make that comment and share that thought.
Thanks, Abby. So just curious, you can drop in the chat too. What types of trainings are you doing within your organization to broach this topic? I think also, even at weekly meetings, right, just having like a case study type of presentation where you can talk about some challenges or best practices in terms of patient care as well is always helpful.
You guys are doing amazing at answering April's question. But yeah, I think even looking at how we started this webinar in terms of saying who NCUI was, what NCUI's mission was, in terms of having that openness with inside your mission statement for your organization and repeating it. And having that loop, whatever you said, it's not a closed door. It's not, you're not automatically one culture humility training and you're done. That's never how life works, unfortunately. Can't just sleep on a book and retain all of it and have it all. So you just got to keep feeding it one or another. These are great questions. Keep them coming. And you guys are welcome to come off chat too. Not chat. You're welcome to come off mute as well as type your answers in the chat. We have time for maybe like one or two more questions.
Yeah, and Brian says along with cultural humility comes respect. And yeah, that is the heart, of this definition. Respect for everybody that, you interact with or comes through the door.
If I may ask another question, this is Vince Villela from Norton Sound Health Corporation in Nome, Alaska. A follow-up question to the question I asked earlier. One of the challenges we're running into is not so much that providers are struggling. Well, providers do struggle with patients and cultural humility, et cetera. The struggle I'm talking about is between our tribal healers. So we have like established, trained tribal healers program, and sometimes we run into conflicts where best practices in that discipline are different than best practices in Western medicine. Now, these are navigated kind of on a one-on-one basis, but I was just curious if you had any insight on how to best navigate the differences in best practices between those two disciplines.
Vincent, I'm going to do my best to answer your question, but guide you to an example or an actual experience working with the Navajo Indian Health Service system. What they have done specifically in the Chinle Comprehensive Healthcare System, as an example, they have Western medicine, clinical services, and also they coordinate their services with the tribal, members, the healers, the local healers. And so and this project happened, I want to say over 10, 15 years ago or so. They built something called the Navajo Wellness Model. And that wellness model today is utilized in diabetes care, in elder care services, in a public health setting, public education, schools, school health projects or programs. But what they've done is they actually had a convening with the tribal healers. with the practitioner from IHS and the tribal healers sat down and really had these candid discussions, right, on both approaches, and were able to integrate and come up with this new set of fundamental teachings that would really address and you know the needs of different projects and programs, and it's widely used in diabetes, for example, and all of those other examples I've shared. But I think it's really important to continue. It sounds like you've already have an established relationship with tribal healers in your community with your practitioners. I think that ongoing communication and really having those candid discussions is really important, because all across Indian country, I think that's the ultimate challenge, right? To really come up with those crosswalks of Western medicine, and how does that measure up, and how does that even up with some of the standards of care that we might see in tribal medicine. And I think that is the work of today, and I think it's an ongoing work that will continue to occur. So I can't speak for other tribal nations, but that's exactly what happened with Navajo. And so once that curriculum was built, after that flowed training to the Indian Health Services, the different programs and projects within IHS, the tribal health departments, the public health, entity as well. And so they've really integrated or made that effort to integrate the fundamental philosophies that may have come from the traditional healers and also Western medicine, and where is that common ground, and how do we come to that point where we all agree. So I just wanted to share that, and I hope that's helpful, and I hope that's kind of answering the question that you're posing.
Thank you.
Yeah, it's called the Navajo Wellness Model. It's used in the Navajo area Indian Health Service Unit. And I think it's also with the Navajo Nation Division of Health with some of their public health education programs.
Great, thank you, Evie. So we are at time to wrap up the Q&A, and so we'll go on to the next slide, please. So we know that many of you today do hope to earn your continuing education credits, and we're super glad to be able to offer them today with this webinar. So all you need to do is to take out a smartphone, and again, we will send this slide deck to you at the end, so you can retrieve them later on. But you can scan this QR code to earn CNE credits and social work credits today, NASW credits. And if you don't need to do the credits, you can still scan it because we would love your feedback on this webinar for our own improvement and to hear other topics that you might like us to present on in the future. So next slide, please. Something else that we wanted to share, NCUIH does provide technical assistance on a number of different areas, from community and staff training. We can provide help with research and evaluation, program planning, implementation, grant review, application, partnership development, and other operational needs. And so you can find the link on our website to our technical assistance for your organization, or on this slide deck is also the link as well, but perhaps Abby can drop it into the chat. Next slide, please. And then we do have some really great learning events coming up. Again, this training is in the first of a 3-series webinar on workforce development. So we have 2 additional sessions. March 28th, we have one of our UIOs presenting on sustainable workforce growth through internships, and then April 9th, we've got a great webinar on engaging elders into the workforce and bridging the workforce gap. So 2 really great webinars to continue this series. On the 20th, we have a webinar on missing and murdered Indigenous people prevention. And then we have a few other opportunities to share your experience through a project we're doing on photo voice. And there's a link here that you can look at. And then we also have a funding opportunity for ECR implementation. And last but not least, we have our annual conference being held at the end of April in Washington, D.C. So if you're interested in attending that, please let us know. All of this information can be found on the NCUIH website as well. And last slide, please. Here are just some references. We will share this deck out again that helped inform our webinar today. And last slide. And with that, we're going to wrap up this presentation. We want to thank you all for coming, for participating today, for participating in our Padlet. And we should have these slides over to you and the recording for you to share out sometime, I would say early next week. So appreciate you all for taking the time out of your afternoon today. Have a great rest of your week. Thank you.